Great, it's great to see you out there. I hope you don't mind, but I stood over there and I took a picture of everybody and sent it to my wife so she knows what I'm doing. She's a stage actress, she's in theater, and she normally speaks to crowds of this size. I don't, so this is new for me, this is a lot of fun. I do enjoy being here, I do enjoy being with my people. When I say my people, I moved to Los Angeles 2 years ago because my wife, in addition to being a theater actress, is also a screenwriter, and we lived in Atlanta, Georgia. She said, Mike, if I want to have a career in screenwriting, which I want her to because I'd like to retire someday, I need to be with my people. My people are in Los Angeles. So I said, fine, we'll move to Hollywood. So that's how I got to Cedars-Sinai. We moved to Hollywood. But this profession that we're in, I have a hard time describing this profession. My kids, I have a 16-year-old and a 12-year-old. My daughter was at career day, and the teacher went around to all the students and said, where does your family work? Where does your parents work? Well, probably like you, and probably physicians in the office, in the room here. But they went to my daughter and said, where does your dad work? Where he works at Cedars-Sinai. She goes, oh, is he a doctor? Well, you know, she's looking for doctors and astronauts and lawyers, and she goes, you know what, I have no idea what my dad does. And so she came home and said, Dad, what do you do? And I thought, well, I do this. Let's go back. I said, well, I help people understand their problems, and I help people frame the questions to be answered, and I review models and help adopt them. And she said, that's boring. So I have no idea what I do. I went to my son and said, son, when you grow up, what do you want to be? He said, Dad, I'm going to be a professional gamer. Okay, went to my daughter, said, when you grow up, what are you going to be? She says, Dad, I'm going to be a movie star. So I know that they're going to be in my house for a long time. But, you know, in this world, you know, I want to talk about what is it that we do. And all the sessions here, we talk about the learning objectives. And our learning objectives here is to discover how we frame the problem for hospital flow. Hospital flow is a combination of problems. It's a combination of understanding who's coming, who's leaving, and what happens in between, how we get them through the system faster. Discuss how we engage leaders, because machine learning and artificial intelligence has got a cachet and an advertising name. We must fight that name with a way to go through and implement it, and then learn what machine learning models we used, and the results didn't make any difference at all. Cedars-Sinai, the little story about Cedars-Sinai, located in Beverly Hills, which means that we're known as a hospital to the stars. We have 7,000 babies born per year. A couple of them are Kardashians. We have 50,000 inpatient visits, 2,000 physicians. We are an academic institution. We don't have a medical school, but we do have residents and fellows. We have another hospital in Marina Del Rey we bought 3 years ago. We're bursting at the seams. We do have ambulatory practices as well. But although, like I said earlier, we're known as a hospital of the stars, given our location in Beverly Hills, 50% of our patients are on Medicare. So we do have a very large dichotomy between very wealthy and very affluent and a large homeless population. So if I was going to be homeless, I would do it in California too. What this does not show you, though, this slide does not show you, is I joined Cedars-Sinai 2 years ago. The same time I joined, the chief operating officer, who's been there for 10 years, was retiring. The chief medical officer, who'd been there for over 30 years, was retiring. The chief nursing officer, who'd been there for 35 years, was retiring. And our chief legal officer was retiring too. So the whole chiefs was switching out. With them was going institutional and intuitional knowledge. I find this a perfect opportunity to introduce data science, because in our data warehouse, we had all the decisions that were made and all the outcomes of the decisions that were made. We just need to tease it out with data science. So we built a team. I report to the chief medical officer, who we're still searching for. I report to the president of the medical network, and I report to the chief information officer. We took all the analytic teams from those different groups, and all the data teams from those different groups, and formed what we call enterprise data intelligence. We call it enterprise data intelligence because our goal is to take data and help it use intelligence to make better decisions. Find the patterns in the data. Now, what I'm going to talk about today is a new team we formed in there. I got data warehousing, I have data quality, I have data analytics delivery. And let me give you the secret how I got this job. They'd been searching for 3 years for somebody, and they got tired of searching for somebody, and they actually found somebody who actually moved to LA for the housing costs there. I said I'd move there. But my interview, they said, Mike, describe to me why analytic and data teams need to be together. So I went on the board, and I drew the picture of a flower and a pot. I said, analytics is the flower, data is the soil in the pot. They have to live together to make something of it. Data alone means nothing. Analytics alone, you'll do something, but it won't grow where it needs to be. So the pot needs to be together. The CIO said, makes sense to me, you're hired. So what I'm going to talk about actually is this data science team that we've hired. This is a new team we developed. The work I'm showing you to is not my work, it's the work of this wonderful group of people. We hired 3 data scientists. We hired for attitude and aptitude. Aptitude, can you do the job? Attitude, are you humble enough to do the job? So we hired those people there. So Dennis Walsh, Ming Young Joe, Ming Young came with me from Georgia, and Matthew Wells, a wonderful improvisational comic, is also a data scientist who's on that team. They've done wonderful work. Ron, John, and Eunice are our data engineers. Todd Davis is the leader of that group. And we have an advisory services team that hasn't been involved in this project, but they will be. And those are the teams. So I represent those people as best I can. Now, the data engineers. Before we talk about solving the problem, let's talk about the reason we want to make a repeatable process. This used to be a more complicated slide. I can't get less complicated than this, but we have created a data platform, a data science platform. We ingest all the data throughout the institution. We did have an enterprise data warehouse. We want to ingest more data than the enterprise data warehouse. We take all electronic medical record data. We take all device data from the bedside. We take all patient data from surveys. We take all, we work with Apple Watch quite a bit. We take all Fitbit and Apple Watch data, and we put it into our data lake. When we do that, we catalog that because most of our projects we find within data science, you're trying to find that data. So we spent the last 18 months building this whole enterprise data science platform. We have a data warehouse. We use a combination of technologies. You want to talk about Hadoop, we can talk about Hadoop. You want to talk about columnar data stores, we can columnar data stores. We have all that stuff sitting in there. We have open source programming language tools we use, R, Python, lots of debates on which one's the correct one, but we won't go into that right now. And then we have a data visualization platform. Now the key is, this is our technology. We don't talk about anybody. This here, we gave it a name. And that's the most important thing we ever did. Because when we're working with our stakeholders, we gave this thing a name. We call it Alex. Now, the lore is Alex either stands for the Library of Alexandria, which back in the Greek and Roman times was created to store all of human knowledge. So they tried to store all of human knowledge in the Library of Alexandria. So we said this is going to store all of the knowledge of Cedars-Sinai. Or it stands for Automated Learning by Example, machine learning. That's what Alex stands for. Or it stands for the middle name of my child, Craig Alex Thompson. It stands for Alex. Now, why is that important? Because we told the individuals in working this project, you are going to help make Alex grow. It's also important, too, when you get an email from Alex that says, we predict census to be 850 tomorrow, they say, oh, this is a human being. It's personified as a human being. They're no longer afraid of a machine. They think Alex is a person. And 2 weeks ago, I got an email invite wanting to have Alex come to a meeting. So this is great. They're now referring to Alex as a human being. The other thing is I can never hire a person named Alex into my team because they'll say, oh, you're Alex. And so when we start a data science project, and this particular one on hospital flow, we started by bringing together all the leaders. Now, for 4 years, the organization has been working on hospital flow. And for 4 years, they've been bringing together teams of individuals to try to understand what it is. So we brought those leaders together, and a key component is we have a data science team married together with operations, nursing, physicians, case management, and patient satisfaction. Now that's key. Since I report to the chief medical officer and the president of the network and also the CIO, I'm seen as Switzerland and neutral between business and IT. And so we try to embed ourselves directly with them. And every meeting we have, every week, we talk about a problem. We bring the data and analytics to that problem. And every week when we have the meeting, the data scientist's job is to bring some kind of new piece of data to that problem. So that's how we formed that team. Now let's get beyond this a little bit and talk about the problem. Hospital flow is a problem. Getting patients through our system is a problem. But where does that problem start? That problem starts when you have capacity constraints. Capacity constraint is when your census volumes exceed 80% of your capacity to meet that. In 2018, 12 hospitals in California with beds greater than 300, exceeded 80% capacity on a regular basis. So these are each one of those lines there represent a hospital in California greater than 300 beds. And you can see that with the lines just 80% and above, some are at 100% capacity on a 365-year basis. We are at 100% capacity at 220 days out of the year. That is a problem. So the question that came to me is, Mike, we need to solve hospital capacity. So we do have a poll question, so I can take a drink of water.
All right, so poll question number 1, over the last year, how many times has your organization experienced capacity strain? A, less than 25%, B, 25 to 50%, C, 51 to 75%, D, greater than 75%, or E, unsure, not applicable. So this is a reminder, this is Wave 2, Session 11, Question 1. So if you can take a couple seconds to pull out your phone and respond, that would be great. We'll look at the results here in just a sec. All right, let's go ahead and take a look at the results here. So it looks like this topic is very relevant, and that's why a lot of people are here in the room. A lot of people are experiencing capacity strain, almost 34%, and the vast majority above 50%. So I'll turn it back to you, Mike.
Fantastic. Well, not so much, but that's cool. So let's go to the next slide and talk about the impact of capacity strain, because I think you guys will resonate with this. When you have hospital flow or at excess capacity issues, patients are boarded in the emergency department waiting to be admitted to an inpatient bed. 65% of our patients who were admitted into the inpatient bed from ED had a boarding time greater than 2 hours. So they came to the ED, they needed to be admitted, the order's done, but we had to wait more than 2 hours for them to get into an inpatient bed. Anyone experience that? We had ED crowding, left without being seen. Well, when you have left without being seen or crowding where patients are waiting to get in the ED, ED's getting backed up, 280 patients a month at Cedars-Sinai go home left without being seen. That's 3.6% or 3.8%. That's 280 patients who said, I need to go to the emergency room. And they got fed up and left, 280 patients. The edict that came down from our CEO, I want 0 patients left without being seen. We had delays for surgical procedures. We had staff schedules. We had patients had overnight stays in post-op rooms. We had ICU readmits within 24 hours. So what that was is that they left the ICU, went to a bed, with 24 hours, they went back to ICU. So obviously we discharged them before we probably should have discharged them to the downgrade. We had delays and cancellations of surgeries. Physicians and nurses were feeling overloaded, and throughput is decreased, which means that there are delays in transferring patients to appropriate units. 99% of every day of 2018, at least one patient was in an alternative bed that we prefer for them not to be in that bed. 99%. What does this mean? This means we were not serving our mission. Now, I can go back to that slide before and say, oh, Cedars-Sinai and U.S. News and World Report was ranked 8th in the nation. But this is the reality. This is our dirty laundry. We were not serving our mission. We weren't serving the purpose that we exist as a nonprofit. Patients were going, patients couldn't get the right rooms. So what was the goal? The goal of creating predictive analytics was to solve these problems. We had surge planning. 66% of every day of every year, we were in an emergency status of figuring out where should we put a patient, how many patients are coming in, how can we discharge a patient, who should be discharged. These were surge planning events that were supposed to be urgent, right? Diversions of the ED, overcrowding of the ED, we want to reduce that. We want to eliminate waits for surgical procedures. We want to improve staffing where we match the demand to schedule. We want to increase the number of patients admitted to the appropriate patient unit. We want to utilize case management strategies for length of stay outliers. We want to improve discharge and bed capacity, bed management planning. Now, this is where I talk about phrasing the question the proper way. When I showed up, they said, Mike, can you do a prediction for a census model? Yeah, but why do you want that? Because we want to predict census. No, why do you want that? What will you do? What would be the outcome? Describe to me the world after you have the proper census planning. And this is what they described to me. So I said, this is what you really want to do, right? You don't want a model. They came to me, one person came to me and said, Mike, I want AI. I said, you don't want AI, you want this. So that's what we decided to do. Now, I'm going to talk about census, but when you talk about predictive analytic models for hospital flow, you need to talk about arrivals, you need to predict discharges, you also need to predict patient flow of patients in one unit where you expect them to go to the next unit. Those are the different prediction models that you want to put together, that we have put together. But let's talk about the first question, was predicting census. Now, this is the tip of the iceberg. They said, Mike, I want you to predict census. Well, no, you don't. Because what you really want is to predict the admits. And what you really want to do is predict discharges. That's a little more complicated. And to predict admits, you want to figure out which ones are scheduled, which ones aren't scheduled. That's even a little more complicated. So what sounded like a very easy, simple model, hey, predict census, became very convoluted. We're predicting admits and discharge and unit movement. And so we started down here. We said, okay, ED admits, let's predict that first. Now, this is the second hospital I've done this at. And for some reason, predictive analytics starts very well here at ED admits because it is a good time series model. We'll see that. But it also has a lot of volume, so your likelihood of error is a little bit better. Versus if someone comes to you and says, Mike, predict the likelihood that someone's going to have an adverse event. Stay away from that from your first model. Because it's very specific. It's an outlier prediction model. But someone says, hey, can you predict ED volume? Everybody wants to know that, right? It's a very simple model to predict, and I'll show you why. So we went and looked at new patients coming in, new patients requiring a bed. This is 55,000 patients that are admitted in 2018. We said, where's the volume coming from? Well, you can see elective admissions was only 20% of that volume. 80% of our volume was variable. 80% of our volume was coming from something that's unscheduled. So you look at this line and go, that seems like something very variable. You can't predict unscheduled volume. Well, let's see if we can't do that. Newborns and labor and delivery, magically, they somewhat match, 15%. This is then ED admissions was 59%. Transfers from outside was 5%. And direct urgent admissions, as you can see over here, is 6%. And we see medical and surgical admits. Okay, so this is his story. We went through and said, here's our McKinsey diagram of where all the flow's coming in. These are the independent variables. That's a dependent variable, if you ever use that terminology. But let's go through and take a look at just ED census, okay, ED prediction models, emergency department. I was recently speaking to a group of 20 hospital CEOs from France. I kept on using the word ED, and finally the translator stopped me. Can I speak fast? I apologize. I do speak at 90 miles per hour, so it gusts up to 150 miles per hour. But I do that because I didn't start speaking until I was 4 years old. So I got a lot of catching up to do, okay? Anyway, so I kept on using the word ED, and he raised his hand and said, 45 minutes of my presentation, he goes, what is ED? I said, oh, you French. Okay. So for each one of those areas that were unscheduled demand, when you use a time series model, it makes sense. Now, you can use a variety of different models. If you want to play with neural networks, go right ahead. If you want to do random forest, go right ahead. But really what you'll find is that a calendar-based time series model is probably the most common thing you find in literature for predicting unscheduled demand for something like ED. But what you want to do is you want to find out, do we have seasonality? So if anyone's ever used the R package, my team will tell you that Python's the way to go, but I use R, okay? So if you use the R package, you can use that package to look for variability. So you can see here's 3 years of data, and you can actually see some trending here. This happens to be monthly variability within the year. This is weekly variability, days of the week variability. And here is holiday variability. You can see with your eyes right now, there's a pattern showing up, right? I can see over here, and you can see over there. The peaks. The peaks are representative of a pattern. January is our highest amount of ED visits. June and July are the lowest amount of ED visits. When I was at that children's hospital, there's a lot of things going on with children's schedules there with the calendars, but you can see peaks. Weekly, you see peaks. You get this down, you start seeing patterns that exist there. And you can see here, oh, that happens to be 4th of July. You can see that we have lower volume on 4th of July, lower volume on Thanksgiving, lower volume on different holidays through the year. We are Cedars-Sinai, we are a Jewish hospital, so we get lower volume during Jewish holidays. Patterns exist. So we can use that, and here's random. This random here, our whole goal is reduce random variability. This is a really, really fast way to go through and say, ooh, we might be able to predict ED volume. Now here's the next trick that we do. When someone came to me and said, Mike, I want you to do an AI model, I said, which one? So we, in our machine learning environment, and Alex, we have 125 different machine learning models that we can run on demand. We did that because we go through and have an automated machine learning tool that used to take us 6 months to run a machine learning project. A data scientist would start at the beginning, collect the data, go through and run the models, refine the models, run another model, refine the models. 6 months later, we come out with something like this. Well, in our environment now, we do that all in 2 weeks. So we run models on a lot more frequent basis. Matter of fact, when our EMR vendor comes out with a new predictive model, we'll run it through our environment and determine, are we better than what they might come up with? The answer is yes. But that's really because I feel that machine learning is sensitive to your own patients, to your own schedules, to your own insurance plans. Anyway, stop on that for a second. Okay, so when we show a model to a group of people, and this one happens to be the emergency department at Madmet, we show 3 models, if not 4 or 5 or 6. Because we want to train people at the very beginning that models are wrong. And sometimes models are right. But don't expect them to be perfect. I get scared when someone says, I really trust that model with blind faith. No, we want people to learn. You can't be perfect. So this unobserved component is a machine learning model. It's a time series model. Serema is an auto-regressive integrated moving average, seasonally adjusted model. Don't need to worry about that, but that's what that is. That's a common time series model. Facebook Profit. Anyone who's Facebook Profit? A couple people? Okay, so Facebook created a time series model to predict the number of visits to the websites, to each Facebook page. They've done a very good job with that time series model. I can add additional regressors to that model. I can say, here's all my calendar variables, here's all the Super Bowl days, here's all the days that we had smog, it's LA after all, here's all the days that we had rain, not very often after all, here's all the days that we had different variable events. I keep adding events to it, and they become very smart of creating a model. So we're using that one. It's open source. I can call it from R or Python, anything else. So this is the model here that we use. Our mean absolute error is 9, which means on average, we're off by 9.6 patients per day in our predictive model. Not bad, 96% accurate. And if you go look at this over here, this is another validation metric. Different validation metrics mean different things. The one here that we're talking about, root mean squared error, is very sensitive to outliers, so you might have greater variability. So there's not just one metric to use for variability or for looking at accuracy of models, but we can see Facebook profit makes sense. Now here's the other thing that we do. Remember, we don't want people to be scared of the machine. They believe in humans. So we create another model called naive. Naive is, what would you have done, Mr. ED Director? What would you have done, Miss Chief Nursing Officer who's been here for 30 years? She goes, I can predict ED visits. I said, great, how do you do that? I look what it was today, let's say 275, and that's what we're gonna get tomorrow, 275. And if I look at, we had 300 today, we'll get 300 tomorrow. Well, you know what? That model is 94.5% accurate. The naive model is what we had today is going to be the same we have tomorrow. The problem is that there's a lot more variability. So when this number gets higher, you want these to be lower and these to be lower and these to be lower. But when that gets to be higher, that means that you're off more often, larger varying amounts, right? So this is our naive model. Okay, when we sit down with that group, the next thing we do, we always back test our models. We show them how well the model did back testing. So here happens to be one model, which is the Serema model. Here happens to be another model, which is probably the unobserved component model. And you can see the Facebook profit, and the dots are the actual. So we went back and looked at a period, a couple of weeks maybe, and we said, here's how the model performed. And we start training people to say, this is what you actually had, and here's the model that we worked with. Now we asked a group of people, our group of people, to say, which one do you think is the most accurate? Oh, I think this one's the most accurate, Mike. Okay. What have they just done? They chose the model. It's not like some data scientist shows up and says, oh, I think you should do this model. In fact, one data scientist I interviewed had a sticker on his notebook that says, I'm a data scientist, so let's just begin by assuming I'm right. I didn't hire that person. Because we say, I don't know, what do you think? And so they helped us choose the model, but they say, well, Mike, it's not very accurate. Well, what would you add to it? So they add to it, they added some stuff to it, and they helped us improve the model. So you can see now Facebook profit is about 3.72% accurate, and they helped us refine the model. And during the process of refining it, they came to own the model. The ED manager, ED director now owns this model. You say, you know what, I think Facebook profit is like 96.7% accurate. And so he starts using that. Matter of fact, he starts using this dashboard here. We created a dashboard to give to the ED department, the emergency department. This here happens to be what's predicted for the next 7 days. Volume right down here. This here happens to be what was predicted versus the gray what actually happened. And you'll see we also show each one of the models here, Facebook profit, unobserved component, and here we switch down to a long-term, short-term memory model, but we need to talk about that. But we also see what's key on here is you can't see it very well, which we allow the director of the ED to go and start changing different models and see how well it would have performed last week. Most data science projects I start on, we want to say, this is what we predict you to have. And we don't tell them how well we did last week. We don't want to tell them how well we did. We want them to just trust what's going forward. We found that we give transparency and say, you know what? We were a little off on this day. Thursday, we were off by 23. We were a little on this day. We want people to realize that there's going to be errors in our projections. And then that ED director can go up here, and it's not very clear up here. They can drop down that box and say, how would another model perform? And then I get an email. Hey, Mike, I think we should be using a long-term, short-term memory model. He has no idea what that means, but that is democratization of data science. Because he's saying, Mike, I think we should use this model. All right, I think you're correct. So we went through and started creating these models, ED admits, and then from ED visits, how many expect to be discharged directly at home, how we expect to be admitted. That could be a time series model too, a time series on top of that model, or it could be a standard percentage. Most people use percentage. If you have 16% on average that get admitted to the inpatient from ED, most people will use that number there, or you'll find the seasonality. You can use that number there. We started predicting a time series model for here, and then we already know elective admissions. That's what's scheduled. We're done. We know a number of admits that come in. And the emergency department can use this, and now our bed planning unit can use that. And they start showing up in meetings, they start having daily huddle meetings, and they start saying, Alex, could we train them to say, you're building Alex. Alex is a little kid right now. But as you start to give him more knowledge, she'll grow. And so they say, we're building Alex, and they come back and they say, Alex has predicted this number of new patients requiring a bed, but that didn't solve census. We also gave them this dashboard here. You can see here is the predicted values for next week of the unscheduled admits. You can see the scheduled surgeries. You see a pattern. We don't have many surgeons doing surgeries on Saturday and Sunday. So you can see the pattern. You can see the pattern that exists here. People can now start planning for staffing on this. They can start planning for staffing here, staffing there. You know, we had staffing all over the board. And so now we can start planning for this many patients to be in a bed. And here again, you see what we predicted and what actually happened. The gray is right there. The gray is right there. If you can see it, it kind of goes there. And you can see down below our error. So, well, naturally, when a data scientist shows up, he'll say, you know, we're off a half a patient on Monday. We're really good. And then bed planning would say, yeah, but you're off by 28, 26 patients there on Tuesday and Thursday. And we'll say, why do you think that is? And maybe we can add that to the model. So we keep adding more to the model, and they start owning the model. Okay, discharges. Ooh, discharges. That seemed really simple at first. It did. Oh, we did a time series model for admits. Let's just do a time series model for discharges, right? Oh, wait, that doesn't work out very well. So we start out here with the time series model, but we forgot something. Number of discharges is dependent upon number of patients in a bed. So I can't predict how many discharges I think when I have Monday, Tuesday, Wednesday, just on discharges alone. I have to predict about the number of patients in a bed. So then we did an expected runoff model, which is how many patients we expect to run off. Patients we have in a bed now, and how many we expected to leave each day. So I'm just going to go forward just a second. Here is a histogram of a whole variety of patients, maybe over a year, I'm not sure, of the length of stay. And we have this many patients who stay 1 day, this many patients who stay 2 days. You see that? And there's this, the next one is, the next bar is how many patients stay 3 days. So if we assume X% of our patients are going to stay here 1 day, X% of our patients 2 days, we look how long they've been here, and we just run a runoff model like that. Well, that wasn't so good though, because people said that doesn't make sense. You just look at length of stay. So look at average length of stay. On average, a patient in our hospital will stay somewhere between 4 or 5 days. So if you've been in bed 3 days, we expect that probably you'll be here for another 1 to 2 days. That's the average length of stay models that a lot of academic journals will put out there. The problem with that for us, as you can see, our average length of stay has been going down. We've had a census and hospital flow problem for a while. The way they decided to do with that is try to reduce our average length of stay. And then you can see, as we reduced our average length of stay, our volume went up. So we're getting people out faster, we're getting more people in faster, and we're still at a capacity problem. Oh no. So you might say, Mike, why don't you guys just build another wing? We got two towers, right? Build another tower. The problem is we have to build another tower because the 2 towers we have to be retrofitted for earthquake problems. So we're going to build another tower, move everybody out of 1 tower to that tower, but not increase the number of beds. Because we got to retrofit that tower for all the earthquake situations. So we got all the problems going on. Anyway, so average length of stay. Then someone says, don't use that. Use what the doctor says. A doctor says, I expect a discharge date. How many people trust the expected discharge date of the physician? No? Well, how many are physicians in here? Okay, he said, he's a physician. He said, I'm good at this, though. Well, what happens is that 40% of our expected discharge dates were in the past. They're still in the bed, but in the past. We don't have time to update it, right? Okay, and then patient-specific length of stay. This is where I got a little nervous because now we're looking at individual patient and predicting that individual patient's expected length of stay. I'm getting into an area of clinical intelligence that could cause me some problems, but we'll talk about that. So we already saw that. We saw our average length of stay is going down. We saw that this is our expected histogram. We'll look at this histogram a little bit later. You guys with me? This is only the second time I've heard this presentation, so I don't know what it's like from your side, but from my side, I'm a little winded. Okay, this is a good exercise. So before we start any data science project, we go out and look at the literature. We decided that going through all those data models, we must predict individual patient length of stay. People said it cannot be done. There's too many clinical and biological variables. Maybe right. But we found enough of these articles out there that went out there and said, we predicted ICU length of stay of patients. Now, I'm not a big fan of R-squared for a validation of a model, but they did use R-squared for validation of the model. And let's see, I don't know if you can see it up there, but the best R-squared was 0.62. And then, they got some other validation metrics as well. Like I said, I don't like R-squared. Each one of these models use different features, but we went out there and said, this has been done before, so trust us, we're not blazing new ground. We're going to learn and stand on the shoulders of other people and apply those models through a machine learning environment, and we did. And I said we have 125 different models that we can use. This is no longer a time series model. This is a supervised training model, right? So we have 125 different models, and these are the ones that came up towards the top. An advanced GLM blender model, an extreme gradient boosted tree regressor with early stopping. Here's a random forest regressor model, a generalized additive model, a ridge regression, and a linear regression model. I don't want to go into the history of why each one of these models is good or bad or whatever, but you can see that our best model that we had R-squared of 0.4. Again, I don't like R-squared, let's get 0.4, a mean absolute error of 2.73. You want that to be lowest, so that's not so bad. 2.73 is not too bad. But what we do, we go back and we show them that here's all the different models that Alex has run. And Alex has determined that this top model is probably the best model we can do right now, given the features that we have. So they came back and they said, Mike, I don't know. These features don't make sense. For example, if I have a patient that's intubated, I know they're not going to be discharged today or tomorrow. But Alex is saying that he's going to be discharged tomorrow. Well, these models are saying they'll be discharged tomorrow. So we'll add that to it. What other clinical and biological variables would you add to it? Oh, well, I'd add X, Y, Z, keep on going, comorbidities, et cetera, social factors, et cetera. And so we added more factors to the model. Now, anytime I show up with physicians in the room and I say we're going to do predictive analytics, you got three types of physicians. Maybe it's two. The first one is, great, this is going to help me. The next one is, you guys can't do that, that's a bunch of malarkey. And the third one is, oh, wait and see what the other two fight it out for a little bit. But we came back, and you see R squared, 0.87. Literature had 0.62. We're now using 150 different variables, clinical and biological variables, lab results, vital sign data. Remember I said we're pulling in real-time vital sign data? And the other thing that we're doing, too, is we're updating every single patient's length of stay every hour of the day. Every time a new vital sign comes in, a new lab result comes in, every hour we're predicting your expected length of stay based upon that. And then we went to the physicians, we said, here are all the variables that Alex came up with. And then what they said? They said, I knew that. I said, that's cool, because I didn't before this started. And now I've just done what you said is right. They say, you know what, that makes kind of sense. So, but they did come back and say, Mike, I'm a physician, I know better. So remember I said, I'm a little sensitive about going into this area, because I didn't want our first predictive model to attack a physician or to threaten a physician, because I didn't want to challenge it. I want to talk about operations. But now I'm predicting expected length of stay based on individual patient factors. And the answer came back, said, we believe that we're better than the model. We put in an expected discharge date. It's not all the time, but okay, 40% of the time. So they said, oh, before I get there, remember that histogram we saw earlier? Give you guys some love over here. The histogram we saw earlier, our model is predicting this many patients discharged tomorrow, 2 days, 3 days, 4 days. It looks just like the actual histogram we saw before, right? Remember we saw the histogram before that had up and a long curve. This shows up and a long curve. We also go through and look at all those patients that have discharge date greater than 7 days. We go to give those to case management. Case management starts working those people on day 1 to get them out of the hospital. Okay, let's go faster, guys. We got 10 minutes. You guys better stop talking so fast. All right. So, versus a physician. Expected discharge date. So for all the patients who had expected discharge date, the blue line is the physicians. The orange line is Alex. Okay, so what have we just done? On a patient expected discharge date, accuracy within plus or minus 1 day. Typically, we predict 4 days or here 5 days, right? It's really not that many minuses. A physician expected discharge date is correct 58% of the time. Alex is correct 72% of the time. Huh. Okay, how about on the exact date? On the exact date you're going home, it's September 23rd, 2018. Physicians correct 22% of the time. Alex is correct 38.9% of the time. Huh. For patients who are going to stay longer than 7 days, well, those are hard patients to deal with, right? But on day 1, a physician is 14% of the time. Alex is correct 31% of the time. I was nervous about showing this, right? But you know what the answer that came back? Well, of course, Mike, we knew that, because we put in optimistic discharge dates. You see, they might stay here for 4 days, but we put in 3 days because we want the lab orders done, we want all this stuff done so we can get them out. So that's how we use that. I said, great, I don't care. But for planning purposes, should we be using this? For actual purposes, yeah, we should be using Alex. We should be using Alex. That's cool. That's cool. So, this is a screen from May 22nd to January 4th. This is what we give everybody every day now. This is what, you can probably not see it, but here's what actually happened. This is actual down here versus what we predicted. And here's our prediction for the next 7 days for census volume. So this is our predicted census. Remember, we're predicting admits minus discharges equals census. We give this to them every day. and they take a look at that, and they're going to run and look at this dashboard every day. But they didn't. Okay, so maybe because we were too sophisticated in providing too much data, so we thought we could create augmented intelligence. Augmented intelligence, we give them a landing page. Here's your ED arrivals. Click on this to get your ED arrival dashboard. Here's your census. Click on this to get your census. Here's admission volume. Click on that to get admission. Here's discharges. And then we had Alex speak to them. Alex will write an email, and we put it on here. Occupancy is predicted to be at 94% and 92% on May 31st at 7 a.m. for surge and med departments, respectively, et cetera, et cetera. It's now telling them at 7 a.m., 7 p.m., or 12 midnight what it expects to have census volumes. Over here it says advanced discharge planning of an additional 4 discharges per day before May 31st would likely result in reduction of census from 792 to 775. Alex is now giving them some ideas what they might want to do. So we thought, augmented intelligence. And this is great. We love it. People are going to start running to use this. They didn't. Now, they did pull it up once a week. They pulled it up on Tuesdays, because on Tuesdays for our advanced bed planning meeting, they always show the data. But, you know, they stopped looking at this. So we said, what are we? What are we really doing? I was watching Dallas Raines. Dallas Raines is a weatherman on a station in sunny California. Dallas Raines, what an interesting name. He should have become a weatherman. And I said, you know, he's sitting there good, there's a 60% likelihood that there will be clouds tomorrow. You know, in California, Southern California, there's a 5% likelihood it'll rain tomorrow, right? But he's like, you know, I said, that's what we are. We should stop telling people, okay, this is what's going on every day. We should only tell them when we expect census to be above 850. Because 850 is when we start doing surge planning. So we created an ability to go through and say, low, medium, high, very high chance of rain tomorrow. And here, we send an email out every day that census volume is expected to be high or medium high. So right here on September 6th, there's a low likelihood of it being high census tomorrow. A medium likelihood of being on Friday, a low likelihood on Saturday. And when it reaches these marks here, the orange and the red, we send that out to the executive team of the organization. And then they start their advanced discharge planning. So we found out that we can create these census models, but we should only alert people when we think they have something important to say. Before, we're sending stuff out every day, and they start ignoring it. Now we send this out when we think there's a high or very high likelihood of a chance of rain. And then they'll go through, and we actually have this particular slide that says, here's the actions that you will do when there's a high or very high likelihood. So if there's a very high likelihood of it being above 850 tomorrow, then discharge patients that are holding. You should redistribute staff to utilize break relief. You should call in more staff for the next 2 days. You should only accept Emergency Medical and Labor Act transfers. So this is all the activities that you should do when you are doing discharge planning, or all these different activities here based upon the models. So, poll question number 2.
All right, poll question number 2. On a scale of 1 to 5, how would you rate your organization's effectiveness in using predictive model information to make decisions? 1, not at all effective. 2, somewhat effective. 3, neutral. 4, moderately effective. 5, extremely effective. Or 6, unsure or not applicable. Just a reminder again, this is session 11, question 2. If you can take out your phones and respond here, we'll pull up the results. All right, let's go ahead and take a look at them here. Okay, so it looks like the majority of us feel that it's either not at all or somewhat effective. And some of the takeaways I'm getting from this is to really see if we can't start with some simple models and be collaborative in some of our machine learning efforts to really kind of get a lot of those quick wins and make sure that we're working with other departments. All right, back to you, Mike.
Yeah, let's go to the slides. By the way, I'm up to 1,000 steps right now, walking back and forth. This is cool. This is fun. Okay, so next. We decide we're now predicting discharges per hour, census per hour, and we create a mobile app. Now, we have a mobile app because Alex started taking on. When we send the alerts out, people start saying, oh, I should pay attention. So now we have a mobile app. And during the day, the COO, the chief nursing officer, all these individuals from the C-suite on down, even the discharge planning manager, will go on the app, and they'll see on their app what the expected volume is to be for certain periods of day throughout the year, throughout certain hours of the day throughout the day. So that we're trying to make it usable and put in people's hands. We've done that now. This has led to a variety of different apps that we have created. We now have a hospital flow app that we're looking at, the hospital flow. We have looking at transfer churn rate where transfers are occurring. We're predicting ED boarding, so now we go through and predict, because we're predicting ED volume, and because we knew the inpatient volume, we started predicting ED boarding. And we start seeing ED boarding creeping up to be 2 hours, or expect to be 2 hours within the next period of time. They start taking actions faster, so we have ED boarding. And then we started doing OR optimization. We created a what-if app that allows people to go through and say, if I take my Tuesday surgeries, and they're here usually 3 days, I move all those Tuesday surgeries to Thursdays, what would be the impact of census, regardless of the impact of the surgeon? What would be the impact of census? So now they're playing what-if games with these models we've created. So what have been the results? Well, the predictive models, let's go back to that real quick. I skipped over it. On average, we do this every quarter, but this is for the year 2018, we're 93% accurate historically for what we predicted to actually happen for admission prediction. We're 91% accurate for predicting discharges. We're 97% accurate for predicting census every day. And you can see that we start predicting within bounds. The red is what actually happened. The blue boundary rights is what actually happened. So we're about 97% accurate. We opened a discharge lounge. The discharge lounge purpose is to get people out of the bed so they can get them, so we start using the beds. We've increased the discharge lounge by 200%, which doesn't mean too much to people, except that means we've freed up 375 bed hours per month. 375 bed hours per month to the most important time, which is 11 p.m. on, to get people in there. So our discharge lounge is now being used. Now, when you talk to a patient about using a discharge lounge, they don't want to go. But we've trained people to find those patients who are at a high likelihood to be able to go to a discharge lounge. So that's occurred. We have daily bed huddles, 50% increase in discharges before 11 a.m. Okay, before this started, our discharges before 11 a.m. was 200. Now our discharges before 11 a.m. is 700. When we went through and said we predict this patient's length of stay, the day before, if we say this is the patient we expect to be discharged tomorrow, they start discharge planning the day before for those patients. We've got to get them out before 11 a.m. we've reduced ED boarding. I don't think I have the actual stat on that one. But I will tell you this, what we have done, we've reduced the median discharge time by 1 hour. Now, we did that through this project over 3 to 4 months. And our electronic medical record vendor called us up and said, you guys are doing something wrong because the data looks wrong. So that's what we've done. We have no impact to patient experience and no impact to the overall readmission rate. So what lessons we learned? Well, hospital flow is not a single department problem. It must involve operational clinical leaders. Everybody wants data, but they want to interpret the data differently. Data architecture is critical. For operation initiative to exceed, you must have a passionate, credible champion on the operations side. Getting people to look at dashboards is tough. Do not overestimate the knowledge of your users. Do not assume they have strong statistical knowledge. Frequent meetings are required, and at every meeting, your data scientist must bring some new insight. I believe that data analytics can assist human, and data science is not a singular event. It goes on, and it goes on, and it goes on. So while we started predicting out some of these, one data science event led to another data science event that led to another data science event, and they're all interconnected. And so we continue to build these data science events. So when my son goes to career day, he'll say, come back home and say, Dad, what do you do? Give me one word of what you do. I don't know what to say anymore. Because we're historians, we're librarians, we're scientists, we're therapists, we are arms dealers, we give data to clinicians, we give data to financial people, we let them shoot it out. We are a variety of things. I don't have one word, but I do know one thing. We are changing and serving our mission in healthcare. So thank you.
Thanks, Michael. I think we got about time for maybe one real quick question here. And if I'm going to look at the one that got the most answers,
Okay.
or most kind of applause, how did you reduce the development time from 6 months down to 2 weeks?
Okay, so when we created that data lake, we made sure we had a catalog of all the data that goes into the lake, and our data scientists are been involved at every step of the way. So I go to a data scientist and I say, do we have medical advice data for heart rate? And they already know that exists inside that data lake, so they're very strong in understanding that. I have to go collect that again. The other part, too, is our automated machine learning process. When we can run through 125 different models with a click of a button versus running it sequentially, that's what took us the most time. Because we were running one model, validating a model, running another model, validating a model. But we run them in parallel now. So we create a massively parallel environment to run all the models, and that's how we reduced it down to 2 weeks.
Yep, perfect. And I think we're at time. Thank you once again.
Thank you.